So good morning, everybody. On this, I would not say auspicious because it's a World Health Day. But at the same time, we are facing a major. I call it World War III, and we are facing a major problem with COVID-19. And today's talk is a comprehensive summary of what I have gleaned from various sources by reading on the internet, by talking to so many people, by looking at the experiences over the last 2 or 3 months when we have been seeing this disease slowly unfolding in front of us. As Niranjan has so nicely and Komal has introduced me, I am really grateful to them and to Science Integra and to all the sponsors of this
Thank
particular
you.
program. I would like to go straight to the etiology of the COVID. Uh, it is basically a bat virus, and it has got 96% similarity to the bat virus, and its genus is beta coronavirus, and family is Coronaviridae. This virus has crossed. You have to cross two species. It has jumped from the bat to another intermediate species, and then it has entered the human cell. The name corona comes from the crown. If you look under the electron microscope, this virus is like a sun. It has got a circular and there are spikes, and that's why it's known as coronavirus. There's a lot of family of coronaviruses which we have. The commonest is the common cold that was discovered in 1960. It is called 229E and OC43. Then we had the SARS-CoV virus in 2003, which called the SARS epidemic. Then we had the MERS-CoV virus, which was discovered in 2012. And there were three epidemics in 12, 13, and 14. And then this virus suddenly came up in China, and it's called the SARS-CoV 2019 virus. It is similar to the SARS virus, and hence it is called SARS-CoV-2. And because it's new to our human species, and that is why it is called novel virus. So it's a new to the human. The humans are not knowing this new RNA that is confronting it, and that's why it was called the novel COVID virus 19. And on 11th of February 2020, WHO renamed this virus as coronavirus disease of 2019. Hence, it is called COVID-19 disease. If you see this virus, this has the spikes of the virus as it's a trimeric glycoprotein spike, and it is called spike S, and it has got two parts, S1 and S2. S1 has got four subunits A, B, C, D. S1 attaches to the angiotensin converting enzyme, that is the ACE2 enzyme, which is there present on the cell surface of lung cells. And following this, S2 triggers the conformational change that enables the fusion of the virus and the cellular membrane, and this results in the entry of the virus into the cell where it replicates, proliferates. It uses the whole DNA mechanism of the cell. It enters the nucleus, it replicates itself into thousands of mini virons, creates a capsule, and by the process of exocytosis, it bursts the cell and it again infects the adjacent cell. This is how the cycle keeps on growing. The antiviral antibodies, hopefully at one point in time, the IgM and IgG antiviral antibodies, they will be targeting the receptor binding sites on the S subdomain, either the S1 or S2 subdomain. If you look at its spread, it started in Wuhan in China, and it was officially registered by WHO on the 31st of December. It probably originated in the Hunan seafood market. We are not sure about that. And it was called SARS-CoV-2. SARS virus was called SARS-CoV because this was similar to it. And it has got 70% genetic similarity to the original SARS-CoV. This was called SARS-CoV-2. On 6th April, that is yesterday night, there were 1.2 million cases infected and 69,527 deaths as per the Wikipedia information that I got, and the mortality rate is around 5.7%. If it normally infects the human through the upper respiratory tract using the ACE2 receptor present on the lung cells, and normally it is asymptomatic for 2 to 14 days. It has a incubation period, and there is a mean infection period of 5 to 7 days. So normally after infection in 5 days time, the symptomatic behavior of the virus will start manifesting. If you look at the infectivity of the virus, you need to have either a travel history or a disease history. But as I told you, the biggest problem is the super spreader, the asymptomatic carrier. And this is going to be a problem for us in our private practice in the future as well. And of course, the healthcare workers also can be infective. As I told you, the infectivity starts from the day 0 till day 28. highest infectivity period is between 7th and the 21st day of the cycle. And normally we define that the patient will not be infective if the symptom disappears 72 hours after the disappearance of symptom, or two consecutive RT-PCR tests have to come negative 24 hours apart. Once that happens, we call it that it is no longer infective. If you look at the symptoms, 30%, as I told you, are asymptomatic patients. These are, however, infect even if they are asymptomatic. And this is the biggest problem that we are facing. And one of the main causes of the lockdown was we had to stop the spread because we didn't know who was having infection, who didn't have the infection. And these people are called super spreaders. 55% of patients who have infection have mild symptoms. 15% have moderate severe symptoms that need oxygen. Normally, in mild, you have cough, cold, fever, sore throat. If you start having dyspnea and you need to have difficulty in breathing, then you need oxygen support. I have come to know that as many as 3 oxygen cylinders may be required per day for each patient. And that's when you, and 5% of these, they have severe symptoms like ARDS that need ventilator support. If you, as I told you, the symptoms can be fever in 88% and dry cough in 68%, dyspnea in 19%, sore throat in 15%, diarrhea 4%. People may need ventilator support in 5%, and some people recently have been shown to have a lack of smell, anosmia, or lack of taste. And so these are some of the other presentations of the virus. As I told you, the period of infectivity is throughout the duration of the infection. So till the two PCR samples 24 hours apart are negative, or patients are asymptomatic after the infection for 72 hours. But that's a way clinical way of looking at it. But actually, academic way of looking at it is the two PCR samples being negative in the testing of the virus. So if you look at the mortality, the MERS virus was actually more lethal than the SARS-CoV-2 virus and had a mortality rate of 37%. But because of its severe mortality, the host could not transmit it very easily. While the SARS virus had a 9% mortality, and the COVID virus has a 5.4% mortality. Males have shown to be more. So many of you gynecologists, 90% of us are females in our association, and females are more protected than males. A lot of mortality has occurred in us weak males, so to say, of the society. And if you look at the age, it increases with age. So if you look at this USA data that has come out, in patients less than 19 years of age, the mortality is nearly 0%. While in patients more than, if you look at the 55 to 64 age group, in which most of our senior fraternity is lying, the mortality rate is 1.4 to 2.6%. So around 64, 65, it suddenly jumps to around 5%. And after 70, it goes to around 10%, and after 85 it goes to around 15 to 20%. People who go on ventilator, so 5% of people who have infection will go on ventilator. In fact, in those who go on ventilator, nearly 50% survival is there. So in high end ICUs, super ICUs, the survival is around 50%, but in a lot of ICUs nearly 80% are dying even though they go on ventilator for 2 to 3 weeks at a time. Especially those patients with comorbidities like diabetes, hypertension, heart disease, obesity, lung disease have got higher chance of dying. And patients who are on antihypertensives may also have a little bit of higher chance. Viral load is very important, and that's why healthcare workers, our children, our friends, our colleagues, younger people who are in touch with these patients should not go more than 6 hours at a time. If you exceed the 6-hour limit of being in touch with a very sick patient, you will start having a lot of viral load that can cause a higher incidence of sickness and mortality in you. A high SOFA score or a D dimer level of more than 1 microgram per ml can also be increase the chances of mortality. If you look at Foxy, when the COVID-19 was had formed, we all had a chat together, and under the leadership of our President Alpesh Gandhi and Secretary General Jaideep Tang, we had a committee which included dozens of gynecologists, including myself, and we came out with two things: the Foxy Advisory and the Foxy GCPR. And both of these are present on the www.foxy.org, and you can access them and you can go into the details. But what I'm going to tell you next is my take on it. my perspective on what is it and what we should do. So if you look at the prevention of asymptomatic carriers, the survival is 3 hours in. So if you look at the droplet, this droplet is a droplet that doesn't cross more than 3 feet or 1 meter maximum. Maybe there is a controversy of whether there's an aerosol effect, but I don't personally feel there is an aerosol effect. This droplet survive 3 hours in air, 4 hours on copper, 24 hours on cardboard, 72 hours on metal, and hence social distancing is very important. 3 to 6 feet distance is important. And there are five principles of which we should always follow in trying to prevent. So if there are asymptomatic pregnant women, she doesn't know whether she's having this virus or not. She needs to do social distancing and use the principles of staying at home, distancing herself from everybody, having a good hand hygiene, 20 seconds of washing hands. You can say happy birthday to you 2 times. If you do that when wash your hands, in fact, it is the soap and the foam that dissolves the fatty capsule of the virus, and that's why you need to wash the hands for 20 seconds. You should wear a face mask, have a hygiene. Like if you're coughing, you need to cough in your elbow rather than cough. You should also have a good respiratory hygiene. So if you want to be very protective, you need to clean surfaces with 70% with either if you want to clean, let's say you want to reuse a mask, which are N95, you have to do it for at 70 degrees for 30 minutes in dry heat, or you can use a UV light box for 30 minutes, or you can use a 0.1% bleach for 5 minutes, or water for 5 to 10 minutes, or 70% alcohol for 5 to 10 minutes. You avoid touching fomites for 24 hours. So if any parcel comes from outside and you are trying to do social distancing, you keep it inside for 24 hours in a corner, wash your hand, and then reuse the parcel. And you should clean the parcels as well if you can with disinfectant. The quarantine period is around 14 to 28 days. Certain states like Kerala have a quarantine of 28 days, but most states have a 14-day quarantine for high-risk individuals who have come in contact with patients who have had infection or you have mild flu-like symptoms. If you look at the prevention, and so what would you do in so what I would suggest is digital consultation is very important. You must minimize antenatal visits, home monitoring of weight, blood pressure, fetal movements. You can tell your patient that you can home monitor your weight, blood pressure, fetal movement. 12 and 18-week ultrasound scan is very important, and you can send them to your sonologist who will monitor it, or if you are your own sonologist, you can do it yourself. Antenatal visits should be deferred, and it's very important to have a 32-week antenatal visit, which is important to see how the child is growing inside the utero, etc. And she should avoid gatherings at 7 months. Normally, we have this 7-month milestone gathering, which should be avoided. And visitors should be minimum, even after delivery, visitors should be minimum. Whenever she wants to come into the ANC, prior information of the doctor is very important, because especially if she is symptomatic, if she has cough, fever, she should inform the doctor so the doctor can take proper precaution to prevent and use the PP and meet her. If you look at the tests, how do you test for this patient? So you can have the antigen test. The main gold standard is to test the antigen using RT-PCR, or you can use antibody test using IgM or IgG. You can either do a rapid test also. You can do a chest CT using an abdominal shield, and all these will give you a good information. Especially the RT-PCR, the symptoms, and the chest CT are used for. The rapid antibody test will come positive 9 days after the infection has started. On 8th or 9th day, IgM will come positive. And I would like you to, in fact, so whom do you test for? The patient with, this is called SARI, severe acute respiratory illness, which is made up of cough, sore throat, fever, difficulty in breathing, and shortness of breath. So if these symptoms are there, they are called SARI symptoms, then you must test these patients. Pregnant women, especially those with associated comorbidities like diabetes, asthma, may present with pneumonia and marked hypoxia also. And if there is any 14-day history of travel or contact with a positive patient. So all these patients you test for. And this is a lovely diagram which I want you to see. If you can see here. One minute. So in this diagram, you can see here that the infection starts at day 0. Then this is the this is the antigen, the blue color, which goes till day 28. Then around the 7th day, the IgM will start, the antibody will start rising. Around 9th day, it will start rising, and around 14th day, the IgG antibody will become positive, and these are the people who have got the permanent immunity in the blood. So this is the way, this diagram is very important, and you I can share it with you if you want anything. So if you come, if the patient is now wanting to, how do you treat COVID positive pregnant mothers? So if you want to treat them, you have to isolate them for mild to moderate disease, either in, preferably in the, would isolate them preferably in the hospital. We would admit this patient for oxygen support and ventilation along with concomitant medical management. Unlike, so in patients who have pregnancy with flu, the flu also aggravates, pregnancy aggravates the disease. But this is not seen in COVID. COVID, it doesn't actually aggravate anything in pregnancy, especially if there is comorbid conditions like high blood pressure, diabetes, or severe. In these patients, there may be a problem. If patients develop disease in the first or second trimester, again they will become normal. We'll treat them, and so the baby is not that in danger. But if the patient becomes pregnant in the third trimester, the pregnant positive in the third trimester, then these patients there is a problem, and we need to give better care to this patient. So, what are the medical management? So, there are two major groups of patients. One is the mild cases. This is just the general information which we should all have. So, oseltamivir, which we use for spine flu, also you can give that 75 milligrams twice a day. In addition, you give azithromycin to prevent bacterial infection, 500 milligrams OD. Plus, you can give paracetamol because these people are having very high fever. I've come to know that they are really, we get in, there's a dehydration because severe 100 to 103 fever is there for 10-12 days. Just imagine. So we have to constantly give them paracetamol. And hospital isolation, a lot of people are saying that home isolation can be done in mild patient, but I don't agree that we need to have hospital isolation because these are the patients that can transmit disease to the family. Patients are cured if febrile for 72 hours or 2 PCR tests are negative. That's what I had told you before. If the patient is moderate or severe, so how do you make out, how do you classify it? Based on the respiratory rate. If the respiratory rate is more than 24 or oxygen saturation is less than 94, there is
regarding the total, the way the COVID-19 is being made, the RNA viral structure, the graphs, and the how to go about and treating the things. In the meantime, we'll just get him connected. And there are various questions which have been lined up. I would like to tell now that more than 1,000 people have logged in now, and it's a second webinar of the TOG along with Foxy Medical Disorders Committee. And we will just get Dr. Rishikesh Pai online. Presently, we were discussing about the medical management, where how to go about it, treating the patients who have been diagnosed. What is more important is primarily the hand washing techniques which have to be considered by the pregnant woman, and also try to avoid any touching at the surfaces. And also we need to once they have been diagnosed, they require to be isolated, they have to be monitored with their symptoms, and they have to be starting with the medical management. Right now we are sitting at the medical management situation, and there are various been questions. I got about 50 questions being answered, and it is a very interesting CME which we are having today. I hope you all can hear my voice.
Yes.
Yes, so nice of you. Thank you. I appreciate that positiveness. We will just get back to Dr. Rishikesh Pai. Dr. Komal, in the meantime, can we put what are the latest statistics which are available now with the scenario which is available in India? In Maharashtra, we have got many cases and the figures are just staggering high. So in the meantime, if I can just get the screen share of the Indian statistics. And it's very important to know that when we started the lockdown, on day 1, we had, that is 25th March, the active cases were 562, and now you see them day 13, as of 9 a.m. it is 4,314. The cured cases were 63 on day one, and now the cured cases is 320. That's quite promising to us, and it's really good that we are being able to cure. But still, there are many samplings which have to be needed. Unfortunately, the death has rise from 12 to 118, and one case has got migrated. Even global scenario, I was just reading yesterday. In US, they have got more than 3,85,000 cases which have been diagnosed on COVID, and they are really having a horrendous time there. At least India, we are in a much better position. And similarly, we have the issue also on in UK and Italy and in Spain. So that is the scenario. I just was going, I'm waiting for Dr. Rishikesh Pai to come online. In the meantime, I just read yesterday evening that the Home Department of USA has arrested Dr. Charles Leiber. He is a professor in Harvard, and it was surprised to know that he had clandestine dealings with Chinese scientists, and he received about in the last 3 years he received $50,000 per month, where it was found that he sold, and it would be very nice. Oh, I have a caller here. I have a caller from a special doctor from UK. Can we have that blast? And can we see? Oh, it is Dr. Deep Datta, which I have got now online from UK. It's a wonderful thing, Dr. Deep Datta. I request Dr. Deep to come online. Dr. Deep, can you see me? Can you see
Yes, I
me?
can see you, Niranjan. I
Oh,
can see
thank you.
Komal as
Thank
well.
you so much. Thank you, sir. It is a wonderful surprise for us that you have just joined here with us. And we would like to know the UK perspective. What is the time there in UK? Can we
So
know what is
it's
the time?
just coming up to 7:30 in the morning,
Oh,
between 7:30 and
so
8
nice,
o'clock.
so nice, so nice of you, Dr. Deep. So nice. Well, here in India, we have been locked down for now, 21 days, and we are expecting that it gets lifted on 14th of April. What is the scenario? We would love to hear from you, the UK experience, sir.
Yes, so we don't have as strict a lockdown as you have in India, and I think
Yeah.
that is why we have increasing numbers of patients being diagnosed and treated. But
Okay.
the other thing is, compared to other European countries, we aren't doing as many tests as, for example, in Spain or Germany. So I think we are on the back foot as far as
Okay. Okay. Okay.
testing is
Okay.
concerned.
Okay. I would like to introduce here Dr. Deep Datta to all my audience, which have now crossed more than 1,200. He is a consultant obstetrician and gynecologist at the Maidstone Turnberg Wells NHS Trust of England. In addition to that, he has been a college tutor and a member of the Council of the Royal College of Obstetricians and Gynecologists from 2012 to 2016. He has got many awards, and presently he is serving as an executive committee of the RCOG's initiative in Tanzania and South Africa, and the study is to be done towards safe choices. It's a program for safe and effective contraception in Tanzania. After completing his under and postgraduate medical education from Kolkata Medical College and the BJ Medical College, Ahmedabad, they gained extensive experience in the British Isles, and then he extensively worked on and did his MRCOG later on in Ireland. So this is what we are having Dr. Dev Datta in conversation with me, and to go about and more, he has been also honored with numerous prizes and citations in the RCOG Historical Lecturership in 2011 and the Hind Ratan Award India in 2010. He is also a guest speaker at many national and international conferences, and it was a wonderful thing that we saw him at the C2D2 conference in November 23rd, 24th, 25th in Mumbai, which was held as a presidential conference by none other than our wonderful and loving president of Foxy 2019, Dr. Nandita Palshetkar, and it was a great opportunity for me to chair that session and oration being given. So welcome, sir, and it was a wonderful time to be with you. We have got more questions being lined up, and now we have got viewership going to 1,400. And I'm really amazed by the amount of viewership which has gone up. And I thank Dr. Dev to be there online, and it's a wonderful experience. So, would you like to share more about your experiences of
Yeah,
UK? How is it?
basically, I won't to talk much about, because Rishi has already been speaking
Yes, yes,
about
yes. He
COVID
is going to
management.
join with you, sir, very
Yeah,
soon. He is going to
yeah.
join
So,
with us.
there is a lot of thinking now shifting from active ventilation to actually understanding why the damage is happening. So there is a school of thought that thinks that the glycoprotein in the virus particle actually binds to the heme in the hemoglobin, dissociating the heme from the hemoglobin. And
Okay.
then this iron actually causes two things. One, it causes oxidative stress in the lungs. And the second thing is that the hemoglobin is no longer an effective carrier of oxygen to the tissues. So instead of focusing so much on the ventilatory support,
Yeah.
what we should be doing is probably ramping up the body's capability of carrying more blood cells. So blood transfusion, maybe plasma rich in IgG from recovered individuals, that should be happening more than positive pressure ventilation, because what they are saying, especially data emerging from Italy, is saying that there's a lot of ventilator induced lung damage that is happening now, possibly leading to more deaths. As far as pregnancy is concerned, I agree with Rishi. There is no evidence to suggest pregnant women are at higher risk, but those in the later stages of pregnancy will probably do less well because of, well, immunocompromise, increase in gestational size and body weight and so on. So,
Yeah. Yeah.
especially with high BMI and
What is the
comorbidities
latest?
like
Yeah.
diabetes.
What is the latest count in UK now? As we in India have 4,300. If you have the
So
estimation.
I think in number of deaths, we are chasing the number of infected in India. So if you have got 4,300 people infected in India, we have got 4,900 deaths. I think that tells you the seriousness of the situation in the
Oh my
UK.
God.
So
Okay. Okay.
UK is doing badly. Our own Prime Minister is in intensive care. Boris Johnson,
Yes,
he was
but
admitted
yeah,
last night.
yeah, but he's still in charge of. He's still in charge of the running the government. That's what he is doing, and
Well,
that's
that was last night. I think it's the foreign secretary who's now in charge, but it just tells you that the seriousness of the situation is very dire in the UK. I think Rishi is back now, so
oh
we
yeah.
might be
We will
able
start
to
with the
look up.
medical management. Yes, Dr. Rishikesh Pai, we have a surprise.
I know. I was
Doctor.
told that there's a Dr. Deep Datta is there with us.
Yeah, yeah. Thank you. It
Hi,
was
Rishi.
a surprise, and I would like to tell you now that the viewership has gone to 1,300 now, and really, Dr. Rishikesh, we are waiting for your medical management to start. Please go ahead. Please go ahead. Thank you. Please go ahead.
So if you look at the medical management, the mild cases you can treat with oseltamivir, as I told you, with azithromycin. And normally it should be done in the hospital in isolation, because once they are having positivity, it's better to keep them in the hospital, because there is a high chance of transmitting the disease to the relatives if you stay in the house. If it is
Yeah,
moderate
yeah.
or severe cases, then we would go for a different protocol, especially if the respiratory rate is more than 24 per minute, oxygen saturation is less than 94, there is confusion, drowsiness, and there is a hypotension, blood pressure is low, then in those patients, you would go for a uh, admission in the, and some people of these people may need ventilator support, so to say. If
Okay.
if you look at the labor in these patients, the labor tries for COVID-19 infections, women should call in advance to alert the maternity unit about her arrival. This will give some time to the healthcare workers to prepare in triage and don the PPE. PPE is primary protection equipment. So when this COVID infection took place, I was not aware. I said, "What is this PPE?" Because my Leelavati vice president said, "Rishikesh, can you help me to get some PPE?" So I was very unaware that there's a full form kind of this she should also be met with appropriately donned PPE at reception itself. The reception and triage is in the same room as to be used for admission in labor, and this should be a room with a negative pressure, but it is not available in most of the communities. You should also keep the room free from unnecessary items like decoration, extra chairs, etc., because this could act as infected fomites later on. There should be a restriction on the number of attendees allowed with the woman. You should have only one birthing companion, and the companion should be treated as if she is infected, and all precautions should be taken for the same. As far as the labor room is concerned, the presence of infection is not an indication to induce labor or deliver the woman. Cesarean section may be done for severely ill patients to relieve metabolic and cardiac load. So if there is a severely ill, because most of the papers and the research papers that have come out from China or from United States have the mode of delivery has been cesarean section, though it is not because of the disease, but because of most of them are severely ill and they may land up with cesarean section. You should avoid tocolysis, especially with beta mimetics, and the labor room should be isolated. All facilities of intensive care like HDU, our favorite, our president, Dr. Alpesh, has always said that HDUs should be available, and this disease underlines the need for HDUs. Ventilators should be there. PPE must be there for all, and there should be less number of personnel and birth attendants in the room. Standard protocol and monitoring such as respiratory rate, pulse oximetry should be there. There should be minimum intervention. There should be no water birth. IV fluids, electron, fetal heartbeat monitoring should be done. We should reduce the second stage of labor. It should be cut short, and cesarean section should be done mainly for obstetric indications or for severe disease where there may be other indications for cesarean. Delayed cord clamping has been recommended by RCOG because the chances of infection are not that high for these patients. Designated, as far as the operation room is concerned, you should have a designated OT with negative pressure throughout, so that what is negative pressure, there should be a suction so it can pull out the air from the operation theater. There should be barrier. I feel that when you're doing a cesarean, there should be a barrier. The cloth barrier can be raised in most of our operation theaters nowadays. It is there should be a cloth barrier should be there between the gynecologist and the patient. The PPE usage is a must. Patient also should be made to wear a mask, especially if she is under epidural analgesia or spinal analgesia. Minimize personnel and movement. Regional anesthesia is the best, epidural or spinal, and if you have to give general anesthesia, you have to do it with care. If you look at the anesthesia, regional or spinal is the best because with the general anesthesia, you have more risk of the anesthetist getting infected. And if you at all have to give GA, you must pre-oxygenate the patient for 5 minutes with 100% oxygen and perform rapid sequence induction to avoid manual ventilation of the patient's lung. If possible, a video laryngoscope should be used for intubation to reduce the chances of infection. And there should be PPE. There's no doubt that there should be high efficiency hydrophobic filter between the face mask and the breathing circuit, or between the face mask and the reservoir back to avoid contamination of the atmosphere. So what are the effects of COVID on fetus? The infection is not transmitted from the mother to child. There have been 2 reports of a total of 18 pregnant women, and they have shown that there has been no traces of virus in the mother's amniotic fluid, cord blood, breast milk. Neither has been any in the vaginal secretions. With the limited number of deliveries of COVID-19 infected women at present, there is no evidence of any fetal effects of infection in terms of fetal abnormalities or fetal parameters of growth, amniotic fluid or Doppler indices. What about the care of the newborn? At present, testing is recommended if the mother has COVID-19 infection or if the baby is symptomatic. Breastfeeding can be given with good hygiene practices. Rooming in can be done unless the patient is severely ill. And in severely ill patients, breast milk may be expressed or given from milk bank. Postnatal care and advice to the mother infected with COVID-19 should follow routine practice. If the woman is isolated from the neonate, she should be offered psychological assessment and support. So if you look at the joint, there was a joint statement by the American societies. I have just mentioned 3 of them, but there have been many more. ASR, AGL and ECOG. Can you hear me?
Yes, you are wonderful.
Yeah.
Rishi, you are doing really good.
Can you they have recommended cancellation of elective and non-urgent procedures to conserve resources and to increase hospitals' capacity to provide critical care for COVID-19 patients, and OBGYN procedures for which delay will negatively affect patient health and safety should not be delayed. Like if you have a patient of pregnancy with severe PH, APH, delivery, abortion, ectopic, patients who are undergoing already stimulation, then ovum pickup should be done. In ART, in situations like fertility preservation for cancer, patient is having malignancy, she has to start treatment and you need to take her eggs out for fertility preservation. Older patient with poor reserve, patients who have to undergo cancer surgery, all these patients who need emergency care cannot be postponed. And they have said that the guidelines may change with time. Our own Foxy guidelines are also there, and you can go on the net and look at the guidelines. So, what are the precautions while doing ART? So, those of you who are going to do ART, there are certain recommendations by HT and ASRM. And these recommendations are that the postponement of elective work of ovum pickup and embryo transfer if ovarian stimulation has not been started. Controversy of whether infertility treatment is, see, there is some controversy brewing in this area, and there may be the American Society may come out with another announcement on 13th of April whether postponing infertility can be done or not, because in many of these patients with poor response or who are perimenopausal or elderly, you may, how can you postpone it? It may jeopardize their infertility treatment. So this will come up at some point or the other. Completion of already started cycles by freezing eggs or embryos and avoiding transfers, as we don't know effect of COVID on surgery as well as on pregnancy fetus in the long term. And gametes do not have, but the gametes don't have COV receptors. They don't have the ACE2 receptors, and they are protected by zona pellucida. You need to take proper precautions of avoiding COVID transmission by mainly adhering to proper laboratory practices. And the most important laboratory practice is repeated washing step, which causes high dilution. So if there is some theoretical contamination of the culture media with COVID, repeated dilution will cause minimization of the viral load and there will be no transmission of the disease. What about the endoscopy? So avoid performing aerosol generating procedure. So normally the most important aerosol generating procedure is when you're putting the trocar in, creating the pneumoperitoneum, or you are removing the pneumoperitoneum, or you have done cauterization, there is smoke inside the abdomen and you are sucking it out. So this has to be all done under closed circuit. If this smoke gets released into the operation theater, that can be inhaled and you can become COVID positive. So you must check the trocars whether they are leak proof or not before you insert the trocar. You must create a pneumoperitoneum. Whenever there is a smoke generation in the abdominal cavity, you have to suck it out by a closed circuit suction with a filtration system interposed in between. So all these precautions have to be taken, and if you don't have these precautions, then you need to go for open surgery. So this is the recommendation. What about private protective equipment? So we have body suits, and these are, you need 3 layers. That is, one is the shirt and the pant. On that you wear a gown, and on that you wear a third layer, which is impervious to fluids and water. Then you need protective glasses with a cap or face shield. Then N95 respirator has to be there, and on that top of it you need to wear a surgical mask. You need to have 2 layers or 3 layers of gloves is very difficult to operate, so at least 2 layers of gloves. And you need to have boots, and you need to cover the boots with boot cover. So all this is together, it is known as PPE or primary protective equipment. What about newer treatment? There are 41 diagnostic tools in the process of being formalized. There are 23 treatments which are in clinical trials. There are 5 vaccines in clinical trials. There are certain things like ivermectin which has been used now. There are also recombinant ACE particles are being created, which can, nanoparticles which can combat the virus directly. You have got Favipir, which improves lung function and recovery. You have got hydroxychloroquine, which reduces symptom duration. And you can also do plasmapheresis. So patients who have already become positive and have created resistance by having the IgG antibody, you can create plasmapheresis, isolate the antibodies and inject the severely ill patient with these antibodies. So now let's come to the main part, which is just 5-10 minutes. So what is our future? Like all of us, we are gynecologists, we are our federation. What is the good part? We are saving lives. So we are in the front line. Everyone is praising us as COVID warriors. we will be respected and remembered for our work and sacrifice. Surely we will. Healthcare and health expenditure outlay will be increased by governments in the future. Suddenly health expenditure presently at 1%, and you'll be surprised that 50 to 60% before our PMO launched the Ayushman Bharat scheme, 50 to 60% of people private used to have out of pocket expenditure, but so that outlay will be increased by government. They have already increased it, and maybe after this they will increase it more. Then many investment will be made in the healthcare industry. For example, a lot of people will say, look at healthcare in a different way. Okay, it's a means of investment. What about the bad part? What is the bad part? There is sudden mental, possible physical, including a 1% chance of mortality. Many of us are more than 50 and we may have comorbidities. So we are got a higher risk of mortality, and there may be economic disruption. We have already got financially disrupted. Having said that, as majority of the gynecologists are women, the mortality may be overall very less. In the immediate present, you or your hospital staff may get COVID positive. We have come to know, okay, there was a surgery, you did that, and the patient was positive, and now the authorities have sealed or quarantined your hospital, and you are staring at a very prolonged lockdown and possible continuation of the pandemic till a vaccine is launched. This may result in a long-term financial downturn. In fact, when the Spanish flu came in, nearly 50 million died, and the Spanish flu went for nearly 2.5, 3 years. So there is a possibility that this infection may go on for some time, maybe not in an acute stage, but it's going to torment us. It's not going to go away easily. But many of these infections are known to suddenly disappear. So when the herd immunity goes to a certain level, one fine day, 2, 3 years down the line, one day it will suddenly disappear. How are we going to handle this? How will we tackle it? So I've divided into 3 parts. Changes in the consulting rooms, OPDs. So what are the changes you would like to do in your consulting room? You need to decrease contact. You need to do more of digital online consultation, which you are already going on doing. You should continue doing that even after the disease goes down. Then minimize clustering by giving appointments. So today, nowadays, so many people walk into our consulting room. There are people just waiting for the doctor. So you will have to be more specific and targeted in giving your appointment. Each patient should be asked for history of COVID, history of contact, history of SARI symptoms, and you must test each patient for their temperature as they enter your clinic. Patients and relatives, not more than one relative should be allowed, and they need to be made to sanitize their hands and given a simple surgical or cloth mask to wear when they are entering your consulting room to talk to you. And when they're sitting in a consulting room, you can educate them on distancing, sanitization using your television or pamphlets in the waiting area. Keep distance of at least 1 meter. So when you are in your consulting room, at least 1 meter, 4 feet, 5 feet distance, sit a little bit away from them so that when you are talking with them. And you must, according to me, you may wear a surgical mask, but I personally feel that because we are healthcare providers, our viral load is going to be more. Suppose you see 40 patients out there, even if 2 are carriers, asymptomatic carriers, you are going to be exposed to more viral load. So you must wear an N95 mask. You must wear a glass or a face shield. Remember, the 3 entry points of the virus is the mouth, the nose, and the eyes. We are not protecting the eyes. So you must wear the glasses, and you must wear the gloves. What about indoor hospital practice? How would you change your indoor practice? Upgrading your facilities, sign up with Foxy Manyata project, which will gives you 16 standards. I was talking to Dr. Hema Divakar yesterday only that I said maybe we should add the 17th standard of Manyata, how to also upgrade a facility for COVID positive patients. Decrease clustering. Maybe we may have to go for single rooms, because if you have a common ward, how can you keep 2-3 patients in the same room? So that may be a thing of the past. Maybe you'll have to start admitting patients in single room. Relook at the air conditioning and ventilation of your hospital. Refitting the operation theatre with air handling unit. I was talking to my person yesterday who does my air handling unit of the IVF lab, and he said that he will put in an additional system of ultraviolet light, which will kill the virus as it is the air is getting circulated in the air handling unit. And they also can put tantalum based catalytic converters, which will create, that catalytic converters, they destroy all the organisms, and they can have negative pressure, so you can suck out the air from the OT, especially when you are doing a surgery of a COVID positive patient. History taking and aggressive testing. I feel this is the most important. Now the tests are available for 1500 rupees. Even the PCR tests are going to fall down as more and more facilities come up. We must, prior to our elective surgeries, we must do the test. It is no, it's out of question. Just like we do HIV test, HBsAg test, HCV test. This is my personal opinion, not positive opinion. As far as the testing is concerned, I totally am for testing. Testing, and more testing. That's the only way that will protect us from the COVID virus. Routine precautions for all and aggressive use of disinfectant. 0.1% bleach solution should be aggressively used to clean surfaces, operation theaters, etc. Proper use of PEP and proper waste disposal is very important. What about changes in your day-to-day practice? I just read this on the Google somewhere, and I've just shortened it. So if you are going to get out of your house, go to your hospital for treating a patient, you will get out by having one pen, a phone, a water bottle which you can throw away, and pack food in a foil which you can throw away. You live in your own car, you sanitize your car. You need to cut your hair short because otherwise the PP and all will not fit properly. No hanging jewelry should be there. You should not avoid trying to use the lift because there will be clustering in the lift. Don't touch anything. Clean the surfaces and handles in cars and consulting room. Wear the mask, goggles, that is protective glasses, washable footwear. Use washroom, and sometimes if you feel that you have to wear the PP for a long time, some people also wear diapers. Of course, normally they use it when they are going into the ICUs where they cannot come out for 5 to 6 hours. But if you feel that you have got incontinence or something, you may use diapers. Inform while returning home. Prior to the returning home, you inform so the home people are ready for you when you come in. When you come in, you need to clean your hand, remove your footwear, put it in one corner, remove your clothes for wash, clean your mobile, then go and take a bath. So these are things that are going to be a part and parcel of your life now. You can't run away from it. You will say, what is Dr. Pai telling us? But this is life, because if you catch the disease, yes, 85% of the time it will be a mild disease. Yes, 15% of the time it will be a moderate disease and you will get out of it. But 2% of the time you will not come back. So this is the fear, and we have to take utmost precaution. After you take the precaution, if you have a problem, I don't care. But you must take every precaution possible to save yourself. What about changes in your lifestyle? I feel enjoy your life in real time. We have realized that we have been all spending time in our house. We should have long-term financial planning. This is a turbulent time. This is going to stay. Our practices are going to fall down. And so we need long-term planning. Save, and save. You must start saving. Consolidation of practice is very important. Human handling of workforce. We are going to face pay cuts. They are our loud, beloved workers. We have to cut their pays. We have to look at the layoffs. It has to be done in a human fashion. If possible, avoid it. But if not, then do it in a nice way. Conservation of resources and savings are very important. And go back to school, relearn and retrain yourself. Maybe we need to do, we are all doctors, we are very intelligent, and being gynecologists, we are super intelligent. So we can relearn ourselves, we can relearn other skills, we can create other sources of income for us rather than just the medical source of income. As I told you, create new business streams. And I would like to end it by what Steve Jobs said. You can't connect the dots looking forward. You can only connect them looking backward. So when after 3 years from now, I can't tell you what is going to happen 3 years now. But after 3 years, when I look back, yeah, you will see if I'm still there in the world, I will say, I should have done this, I should have done that. So you can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future. You have to trust in something, your gut, your destiny, your life, your karma, whatever. And that's what Steve Jobs said. Bless his soul, is not there with us, but I'm sure that we'll overcome this monster, fight this monster, and come back on top. Thank you very much for a patient listening.
Thank you, Rishi. It was a wonderful presentation, and I can tell you more than 1,500 people have joined your live relay by 2AG webinar, and it has come absolutely great. And there are 130 questions which have come, and I would like to start rolling the questions if you may permit me. Dr. Pratap Kumar is there, and he has asked a very valid question. The question he has asked is, hi Rishi, how are you? Everything
Hi
is
Pratap.
fine here. Yeah. But it is basically a question which has said that if we have a patient here who has come at 12 weeks for ultrasound. Do we do that ultrasound or should we postpone it at a later date?
So the 12 weeks is a very important ultrasound, and as I told you in my presentation, that has to be done. So we have to done taking precautions. We must look at it as if the patient. In fact, I was telling my ultrasoundologist, because our ultrasound room is a bit smaller. Most of the ultrasounds are kept in smaller, so we'll have to start changing the size of the room. We'll have to make a bigger room. We have to see that everything is air conditioned. Now we'll have to have ventilation in the room. So,
Yeah.
and we'll have to use a N90. I personally feel that all health workers have to use a N95 respirator. N95 means 95% of the particles are caught. There is a N99 respirator also, but no need. Of course, a lot of people are saying so, and you should make the patient also wear the mask. So now everyone has agreed in the world that the patient may be infective, and if she coughs, she may give you that droplet infection. So the patient, so all of us should wear masks. We as health providers, because our viral loads are going to be higher, have to wear the N95 mask. Whatever anyone may say, we must wear the N95 mask. And I personally would say that N95 with one more surgical mask on top, so that the N95 can be preserved for a longer time. In fact, I can also tell you that N95 can be recycled by using, as I told you, 70. You have to put it at 70 degrees centigrade for half an hour, and you can recycle the N95 mask. So I feel that Pratap, you have to go ahead and do it, because that's so the 12-week ultrasound, the 18-week ultrasound for multifetal anomalies, that the anomaly scan, and the 32-week examination. These are the three tests you must do. The remaining can be done through home monitoring.
What do you think? The quadruple test also at 16 weeks if required in such cases, in such a situation. I request Dr. Deb, if you have some questions to be asked to Dr. Rishikesh Pai. So we
should in fact ask Deb Datta, because he is right in the middle of it now. He is a consultant in United Kingdom, where the peak is going on. We are actually about 1 month behind them, 1.5 months. So we need to take a lot of experience from him.
Yeah.
Because.
Thank you, Rishi. I think your talk was very useful, and it gives all gynecologists and obstetricians a framework to work in. Like you have outlined precautionary measures in conducting the labor and delivery and so on. You might actually also want to bring out some leaflets or guidance for patients and other healthcare workers, like nurses and ayahs, who are actually looking after women in labor. Simple, easy to understand in the local language, that might help them, which is not quite technical and scientific, that we discuss in our Foxy circles and webinars. The other thing, what I'm thinking about is, I hope you don't follow our footsteps in the UK, because your ability, I think, in India, the reason the infection rate is low, a lot of people here are arguing, for a country as size as India, the infection rate is low is because we are not testing as many as they're testing in Spain and South Korea. But your hospitals are not also overwhelmed by people in respiratory distress and needing help with ventilation and so on. So it gives me some room to think that what Professor Kamath was talking yesterday from Anderson Medical Center in Houston, Texas, is that the BCG vaccination might provide some protective effect to countries that do BCG vaccinations generally. In France, there's a trial underway currently where they have recruited 4,000 patients to have BCG and see if they are exposed to the COVID-19. So there's a lot of work going on, like you say. But maybe the strain of virus that is affecting the Indian subcontinent is not as virulent as the strain that is affecting Italy or Spain.
Yeah, I agree.
Absolutely. I think they are talking about the innate immunity, and there were papers being just rolling on WhatsApp University also, that we probably are that much not having that virulent strain which is being going around in Europe and USA, and it's really bad situation, and we are doing our best. Also, the government and the municipal corporation is also doing the best for this thing.
Only
Doctor,
one, Dinanjan, one point I need to make is that the end point is the death. So the death is still comparatively lesser because we can't calculate the actual infection prevalence in the community, but the death rate we can calculate because the deaths are anyway going to come and get admitted into the hospital or they are going to get to the crematorium. So that is one endpoint, which is still the number is still a little reassuring, and we need to keep a watch on that endpoint because, as Dr. Devdatta said, the testing has not been that aggressive. But that testing doesn't testing. Yes, it matters. Testing because we need to identify and isolate because that's what the WHO director also had said some days back when he came on television, that the first step is the lockdown, second is the testing, identification and isolation or quarantining those people that are at risk, and the third of course is the treatment. So these are the three arms of the whole treatment. So once we have, but the testing has got escalated, and hopefully as the more and more ramp up is there, more isolation will be there and less of the
yeah.
mortality will be there.
Can I
Now,
say
sir,
that there is a lot of admiration in the Western media on how Prime Minister Modi has enforced the lockdown so quickly in the third week of March. So there is a lot of admiration for the Indian constraint that is being seen in the lockdown. And I think a lot of European countries are thinking they should have enforced the lockdown and travel and flight ban much earlier than they did.
Okay, there are many questions, but I would have to filter them now. There is one question by Dr. Varsha Lahade. She is from Lasik and she is one of our Foxians. She has asked a question about pathophysiology of coronavirus on RBCs to cause the carbon dioxide intoxication. I think Dr. Devdatta, you have already talked about it.
I was actually talking about this a little while ago. So the dissociation of the heme from the hemoglobin is what is caused by the viral particle protein. The glycoprotein in the virus particle binds to the heme and dissociates so the iron actually then roams around free in the circulation and causes oxidative stress in the lungs. And you have got less hemoglobin to go around, and you have the other organs suffering from oxygen deficiency as a lack. So ventilatory support is one thing, but you also need to bring up the oxygen carrying capacity in the blood, and which the bone marrow already does by increasing the erythropoietin. But maybe blood transfusion and giving, like Rishi was saying, plasma-rich antibodies, IgG-rich antibodies from individuals who have recovered from COVID-19. It's like resuscitating an infant who has suffered from fetal-maternal hemorrhage by just giving the infant oxygen. But you also need to transfuse the infant, the neonate, because the oxygen carrying capacity in the blood is low. So all your oxygen delivery to the lungs is not going to be useful unless that oxygen is carried in the blood by red cells.
Can I ask one question to Dr. Devdatta? In United Kingdom, how many pregnant women who are having COVID positive have gone on the respirator or the ventilator? And what is the rate at which they have come back? Is there any information on that?
Okay, so we have had data of 2 women who were admitted in late pregnancy, 34 weeks plus, in the intensive care. One of them needed ventilator, but she was actually delivered by C-section before she went to the ITU, and she is still in ITU and not out of it. So, yes, that's one we have known.
I would like to interrupt here. So, what do you recommend? Should normal delivery be done, or should be a cesarean section to be done in a COVID patient? Dr. Annapurna has got this pertinent question to be asked to both of you.
Dr. Devdatta has said very clearly, that cesarean should be done for obstetric reasons, and I think he's very sound in that. That is quite reasonable, because the less you expose your theatre staff to body fluids, and you don't know, although there is evidence that it doesn't get carried in amniotic fluid and vaginal fluid and so on, but the less you expose your team to operative procedures, the better, I think. What do you say, Rishi?
Yeah, I agree with you. But however, having said that, all the studies have shown that the majority of the deliveries that were done were by cesarean section. So though obstetric indication is important as a primary driving force for decision whether to do a vaginal or a cesarean delivery. But in practicality, probably the patients that have been delivered have more because of whatever to reduce the metabolic load. I have no idea why they were delivered, but they
Okay.
were all delivered for obstetric reason, but more of cesareans have occurred.
Horses. Yeah.
We have got more than 200 questions now. Oh my God, how will I take it and put it in front of you? But I'm just filtering them as best as possible. And we have a question from Dr. Charu Mittal, and she's also one of our Foxy, and she's saying that what are the main fetal-maternal risks of COVID-19 specific to pregnancy?
So there is no, as I told you, that there is no risk as such that is there for the fetus. There is no teratogenic risk. There is, unlike the Zika virus, which had a risk
Yeah.
of microcephaly, but this virus, fortunately, has had no risk on the infant. Recently, one or two reports have shown one, two positive infants also. Recent reports have shown, but it's too premature to say. From the present data that has come, the transmission is not there. As I told you, there is no virus. They did a PCR, RT-PCR test on the amniotic fluid, the cord blood, the placenta, the genital secretions. None of them had got the virus antigen present in that. So
Now,
uh,
yeah, there is a very interesting question I would like to share with you all. Dear sir, can we conduct deliveries even though we don't have ventilators? It's a very situation we are facing right now in India. A bad situation. We don't
So,
have ventilators.
my suggestion is that, and as in the Foxy leadership, we need to think about this suggestion that presently the biggest problem is going to be the asymptomatic super spreader, and every active nursing home which is there is going to at some point in time have that super spreader, and some point they may have a fever, and they may be tested, they'll come out positive, and then they will quarantine the whole hospital. So first and foremost, the already the I would say rationalization has occurred at the government level. The government has identified COVID hospitals, blah blah blah. All that has done. It's going great. What about at the private level? We have got, for example, we have got a society with 80 members. Each one of them has got a nursing home. How are they going to tackle it? So my request is that in this time of stress, the local society president needs to have of course, a Zoom meeting and maybe identify two, three important large private nursing homes in that society area. And all the gynecologists should concentrate that effort. So their deliveries temporarily, they need to shut down their hospital, everyone delivers in those two, three designated areas, takes their hospital patient, does the delivery, so that maximum input can be given to that hospital, maximum PPs can be done there, maximum control can be done there. That will not affect the economy of all the gynecologists, my colleagues who are there, and we can have a similar situation like the government in the private. So this is how we need to do it. Otherwise, if you are fragmented, each one of us will ultimately have a COVID positive patient and will get locked down. So this is not the way to do it. So we need to have cooperation, and this is where the Foxy has to come in. This is where we should not only come at the time for academic involvement. We should also come to each other at the time of this crisis for personal involvement. This is deals with your practice, with your whole livelihood. So this is the time when all of you have to come together.
So thank you, Dave. He has to go to his office, and it was
Thank
a
you, Dave.
wonderful
It's great. You are
discussion.
looking great also. And
Thank you.
we are praying that you are healthy and all. Take
Yeah.
care and tell
Thank you.
all our friends in the RCOG back home that we are all praying for them and we are all together in this.
Fabulous. And I hope to join you guys sometime soon.
Yes, take care.
Thank you.
Stay
Thank you.
safe.
Yes. Thank you. Stay
Thank
safe.
you.
Stay
Stay
healthy.
Stay
safe.
safe. Stay
Thank
safe.
you.
Stay safe.
We
Bye
can't
bye.
say stay at home.
I know. Stay at home. I know. Take care.
Yeah.
Bye bye.
I'm,
Bye.
I'm actually sitting in my corridor of my Sion hospital. Thank you, Dave. We will get back to you. Thank you. I'm actually sitting in the corridor because of the Wi-Fi connection here, and we came in the morning. We took post-emergency rounds. Luckily, we don't have any COVID positive patient being turned up. But as you know, they might be asymptomatic, and then later on, when the results come after 5 days, when she gets flu-like symptoms, etc., then there is the problem, and then is the issues which come. So, which body fluids contain this COVID-19? There's a question from Dr. Durga Shankar Dash. He is one of our members from Odisha, and he has also asked this question. Dr. Rishi.
So mainly the upper respiratory tract secretions are the ones that are the
Yeah.
COVID-19. Of course, the in the blood, the IgM and the IgG antibodies are forming, but the blood has not. Though there has been some question raised whether one can give blood transfusion or not. What will be the will there be a transfusion? But I don't think that from the whole information that we have got, it is a mainly a droplet. Though there has been certain papers that have shown presence of COVID even in the feces, but there has been no
Yeah,
transmission as such.
I heard that even after the COVID test are, the patients is becoming asymptomatic. It can pass through for the next 2 weeks, but I don't know how much
Yeah, but
is
whether the
is
viral load will be good enough to infect and all, but we have to be careful. But mainly
yeah.
the lung secretions are the ones, the eye secretion,
Now,
the lung, the mucous membranes of the upper respiratory tract. That is
are the
the
most
that's the infection.
contagious, yeah, the most contaminating thing. Now, there's one wonderful, a very difficult question, but Dr. Shetty Mahananda Vishweshwar, can we legally refuse an unregistered labor case if the travel history is positive? I mean, if she has gone to US and UK and she now comes, can we legally refuse, or what has to be done in this
No,
case?
in this patient, you need to send her to the COVID-19 hospital. Na? It's if she's come from
It's
abroad.
absolutely correct.
Yeah, it's very
Absolutely
clear
correct.
na, that you
Yeah.
have to send them for quarantine. And if the after that she develops symptoms, they'll do a test. So there is something called quarantine and something called isolation.
Yeah.
Quarantine is the one where the patient is still not tested positive, but you may suspect that she may have the disease, so you quarantine her. Once she tests positive, then you isolate her. So these are the two differences on nuances. But these patients can be sent to the Dr. Niranjan Chavan is sitting ready to deliver the COVID-19 patient in Sion Hospital. So these patients have to be sent to the government designated
Yeah.
hospitals where they have to be delivered.
Even absolutely. Now there are many questions which are being there, and I'm just waiting for that. My connection had gone, so I request the backup team to send me more questions accordingly, because my connection just went away. And I would like to share regarding Dr. Charles Leiber. He was arrested yesterday because it was found he is a professor at Harvard, and he was having clandestine dealings with the Chinese government and doctors there, and he had received $50,000 per month for the last 3 years, which he had hidden down and had not told the government. So they got him arrested, and they are going to, he's going to face charges now that whether he sold that coronavirus to the Chinese people, and that is what I just came to know about it yesterday. So I thought I should share this, surprising moments which have come across from United States of America. Now, regarding the prophylaxis, Rishikesh, myself, and you or others who are already in the field, they are working in the hospitals. So, should everyone take prophylaxis to be sure, or should we only give to them those
So
who are
the
actually?
yeah. So the prophylaxis as per the ICMR guideline, healthcare workers who are in contact with COVID-19 patients can take the prophylaxis. Hydroxychloroquine, 400 milligram twice a day, and then once
Yes,
a day
yes.
every week for till the time you want. But the problem
So,
is going to be how many weeks can we continue this? So it's a
so the
yeah, of course.
ICMR has said that we can take it for 7 weeks. That's what
7 weeks,
if
yeah,
it. Yeah, if you
but
are coming
I
in.
thought that if we so I no I would like to at this juncture say that there are two groups which are very important. 50 is the cutoff. 50 less than 50 years of age, or more than 50 years of age, or less than 50 with comorbidities is the high risk group. So I personally feel that in the next 3 months or so, when the lockdowns are slowly lifted, I still feel, and I was telling one of my friends just now in the morning, that we have to go into sannyas, especially the group which is more than 50 is the we have to overcome our greed. we have to feel as if we have gone back to internship days where we had nothing. Nowadays, the interns work a lot, but during our time, we had a great time during internship. So I feel as if I'm in internship days now. I'm sitting at home. I have to bed my time. I have to fight the war some other day. I have to see that when I go back and I start my hospital, I need to use my younger colleagues to start the hospital. I know that more than 50, especially with comorbidities, my risk of mortality is high. I have to wait it out for 12 to 14 months till the vaccine comes. It is very important. I don't have to be foolhardy. I need to be wise. I need to be intelligent in handling this situation. I need to save for 12 months more. I know that my income is going to go down over the next 12 months. The economy is going to go down. So naturally, my income is also, a lot of my elective work is not going to be there. I will only do emergency work. So all these things have to be factored into your mind, and you have to go into a defense mode, and we need to re-emerge back after 12 to 14 months right back to where we started. This is how we have to handle this disease.
Yeah, absolutely. There's one more question. If you have done a section, cesarean section on a patient, and then she develops post-operatively cough and fever. So that is the situation which people are facing in the
Yeah.
town areas and not in the the absolutely the urban areas. So what should they do? What would you recommend them in such a
So
case?
the recommendation is she has got a sari like symptom. So you have to do the test. You have to do it, and if it is positive, then you have to take precautions. Suppose if she comes positive, she needs to be isolated, and whoever has come in contact with her needs to be tested. And if they come positive, they have to be isolated. That's the
Yeah, yeah.
as I told you. Is so what we need to do from now on. Every patient is a potential COVID
Yes,
patient.
yes. And you
So
have to
yeah, so we
use universal
yeah
precautions.
precautions, and
Universal
now the
precautions.
new test has come, which is the rapid test. We need to do it. So just like we do HIV, HBsAg, HCV on every patient, don't we do it? So this rapid test, yeah, it is costing 1,500 rupees. So and it is not accurate. It will become accurate 9 days after the infection starts. But still, it is still a good test. So we can do the rapid test. Especially there are symptoms. If 3 days after the symptoms start, you should do it, the rapid test. If the rapid test is positive, or you can even do it on an asymptomatic patient. If it is negative on an asymptomatic, mostly she will not be carrier. I can't say because she may be in the 9 days of phase. So, but mostly she may be a carrier, not a carrier. So you must do the. My advice to all of you is that spend that 1,500 rupees more and do a rapid test on every patient who is going to undergo surgery. This is my advice. You may take it or you may not take it, but I would like to give this advice to all of you.
Okay, now what about MTP? There's one question also which has come. Patient walks in your chamber, I mean, or they call you. Rishi, what happens nowadays when you're sitting at home or you're not going to your clinic? You get video conferences. I want you to share that experiences of last 13 days. What did you do? How did you went about in your routine? I'm not asking any personal
So
questions, but regarding patient
yeah, yeah.
management or anything. About your Bloom IVF, there are 15 centers. There are patients now who have been stuck up with ovulation induction. Few of them are for in the phase of embryo transfer. Few of them already are in such a situation that they can't be, they have already had that ovum and the embryo been made, but they cannot be put in. So, what was your experience in managing all these issues from infertility and IVF point of view?
So as I told you, Niranjan, that I look at it, and this was actually thanks to one of the vendors who talked with me some time back, who I take medicines and all culture media from. He said, Dr. Pai, you are looking at a problem that is not 2 months problem. We are looking at a problem that is a 2 year problem. It's a 2 year problem. Economic downturn is going to be there. A lot of patients will be electrically. So you have to. So I started looking at this as a 2 year problem in my mind, and one of the fortunately in our group of Blue My Way, we do a lot of internet counseling anyway. So we decided that we will keep up. So as I'm talking today to you, all the people are doing digital counseling. We don't need to do fancy things. we like personally took a decision that we are not going to charge them anything, the patient. There's to, of course, you can have a payment gateway, etc. There are a lot of organizations that are there. They will, you can use their payment gateway and they take 30% and remaining money they give it to you for your consulting.
Yeah,
But for us, in our practice, consulting is not a main source of income. You know, it's the procedure that is a main source of income. So in our practice, and we normally what we do is we talk on audio on a WhatsApp, or sometimes WhatsApp video also we talk. That's good enough. When you talk on a video, people they connect with you on a different plane, and they are more connected with you, and you can retain this patient for the future. So the our strategy was to see that the patients that are already undergoing, I told all my junior doctors that you need to talk with them, you need to stay connected with them, you need to allay their fears. They must be psychologically perturbed. We cancer nearly 100 patients. Niranjan, I canceled 60 ovum pickup. I canceled nearly
that's one
70 of.
right. What is
So,
happening?
so I cancelled it. But I said so, and then I said, you know, because I learned this from Mr. Godrej. I had listened to his interview in 2008 when the recession had taken place, and I switched on the television, and Mr. Godrej said, during a recession, you should spend more money. You should spend more money and not spend less money in your business to promote your work. Because if you do that, then you will, when you come out of the recession, otherwise you will go into more recession. So this is always I have followed in my work practice,
Okay.
and this is how I have aggressively increased my digital presence, and that has given us good digital consulting, and that is going to sustain us. But let me tell you, for the next 2 years, there's a major setback for the economy, and this has to be absorbed by all of us. As Mr. Modi ji has said, that we have had good time, now this is our bad time, and this is a time when not only we should absorb, but we should help others also. I have donated to Foxy, I have donated to other organizations. I'm going to keep on donating. But as one of my good friends, Suchitra, told me, "Arey, आराम से donate कर थोड़ा थोड़ा," because yes, it's a long haul. It's a long. We need to help people for a long time. It's just not 2 months. It is 2 years that we are looking at.
Yeah, I absolutely agree. There's one question. We will have to take this last question now. Hello, sir. I'm gynecologist by profession. I'm myself 21 weeks pregnant. Should I practice or take complete rest to avoid exposure from patients?
You have to avoid exposure from patients. You have to
So,
avoid the
doctor,
viral load. You have to
so
sacrifice. The most important thing we need to do is not be greedy. As I told you, this is a very dangerous disease. We have to control our urge to practice only the essential practice, and wait for a sunny day. That day will come 12 months down the line when the vaccine comes. Till that time, you must not take the risk.
absolutely. Now we go and play a wonderful video which I came across yesterday, and I want now. There are about more than 1,800 members who are right now live seeing Rishikesh and Deep Datta with Dr. Niranjan Chavan. And please go through this video. You will really feel great things.
I
And
would like to, before I say that, you know, Komal Niranjan conducted it very well. I was very happy that Deep Datta, who was our friend from United Kingdom, is a consultant. He also came in, and I also had a nice time interacting with all, like Pratap, my friend and my
yes,
very good colleague,
yes.
all of us. So it's been a good interaction, and I'm always available for all of you. Anytime you can phone me on my mobile, and I'm there for you. Thank you.
Yes.
Yeah.
Thank
Yeah.
you very much, Dr. Rishikesh Pai, for taking out time from your such a valuable and giving time for the webinar and answering so many questions. It was a overwhelming questions, and I thank moderator Dr. Niranjan Chavan. I also would like to acknowledge Dr. Alpesh Gandhi, President Foxy, Dr. Jaideep Tang, Secretary General Foxy, Dr. Atul Ganatra, VP in charge for my committee, and the team Science Integra and OakNet for making this possible, this platform, and sharing all these wonderful experiences. Definitely, I think we all have got a lot of things to ponder, to see this as in a perspective from 2 years, not for 2 months, and increase our vision towards this problem. And together, I think we all can fight, and this also will pass. So I'll just start the video, which is there. coming on the screen.
Yeah, it's
It's
come on
come.
the
It's
screen.
come. It's
It's come
come.
on the
Komal,
screen.
just relax.
It's
Yeah.
coming, na? Sorry.
Audio. I want the audio.
Thank you.
So thank you all of you. It was a
Thank
wonderful
you.
time,
Thank you.
and hope this unlocking of lockdown takes place soon, and we will be free birds. And in reality, I appreciated that Rishikesh Pai's post on Facebook. I want to meet. I want to meet my friends. I'm desperately waiting for them. I want to hug. I want to backslap them, and just see and attend all those conferences. And I think we are not very far from that day. Let's be optimistic. And thank you, Dr. Rishikesh Pai, and
Thank you.
all of you to being with us. We had a great time. We'll catch up soon. Thank you, Dr. Komal. Thank you, Science Integra
Thank
and
you.
Open.
Thank you to the both the Chavan, the dynamic couple, and Subbu and Session of Science Integra and the sponsors, and all you listeners for having a patient listening. And I hope you have learned a lot. Thank you.
Thank you.